For example, we have osteomalacia and osteoporosis. Second, we have arthritis or joint-related pathologies, which can be further classified as inflammatory and non-inflammatory arthritis. Third, we have vessel wall disorders, which are called as vasculitis. And depending on the size of the vessel, we classify them as large vessel, medium vessel, and small vessel vasculitis. Then you have connective tissue diseases, which is going to involve predominantly the skin and the musculoskeletal system and other connective tissues. So classical example would be a systemic lupus erythematosus and scleroderma. And then we have what's called as the localized rheumatological diseases, which are basically regional pain syndromes. For example, we have adhesive capsulitis, epicondylitis, carpal tunnel syndrome. So these come under the category of regional diseases. So this is how we're going to discuss the rheumatology in these 6 hours. The first thing is about we're going to discuss is the metabolic bone diseases. Now, in this picture, what you can see is the component of the bone. So this is a normal bone which has got two parts. One is the matrix. The matrix is predominantly made up of the collagen and the mineral. Mineral is basically the calcium and the phosphorus and the calcium hydroxyapatite crystals. Okay, there are two different structural components of the bone: matrix and the mineral. Now, what is osteopenia? So, osteopenia is a generalized reduction in the strength of the bone. Okay, so thereby resulting in the weakness or the what's called as the decreased density of the bone. Okay, so but here the matrix and the mineral component of the bone remains the same. Okay, there's generalized reduction in both the component, both the matrix and the mineral. Then you have a term called osteomalacia. So osteomalacia is basically occurs because of vitamin D deficiency. Now, vitamin D, as we know, is one of the important hormones for the mineralization of the bone. Now, mineralization is important for strengthening of the bone. So what happens in osteomalacia is again weakness of the bone. Now, it's going to predominantly affect the mineral component of the bone. So what do you see in the matrix component is actually slightly enlarged in proportion, but actually there's a defect in the mineral component. This is the osteomalacia. Coming to the osteoporosis. Osteoporosis is the decrease in the matrix component of the bone. Okay, compared to the ratio with respect to mineral component, the predominantly matrix component is affected in osteoporosis, mineral component is affected in osteomalacia. In osteopenia, both the components are reduced, but the proportion remains the same. So this is the general description of these terms. Now let us understand one by one how what are the different causes, presentation, and management of these conditions. The first thing is the osteomalacia. As you know, it is in osteomalacia, there is decrease in the mineralization of the bone. Now, it can happen both in children as well as in adults. If we see this osteomalacia, see this condition in children, it's called rickets. So we don't use the word called osteomalacia in children. It's called rickets, basically because of vitamin D deficiency. The corresponding term in adult is osteomalacia. So you're going to question on the osteomalacia. Now, what happens in osteomalacia is that because of vitamin D deficiency, what you get is decrease in the mineralization of the bone. Now, the risk factor, geographic profile, osteomalacia is seen in those people who have a decreased exposure to sunlight. We know the vitamin D metabolism. So, how vitamin D is synthesized. So, when you get exposed to the sunlight, we have ultraviolet B rays, which will irradiate the skin. In the skin, there is synthesis of a conversion of 7-dehydrocholesterol into what's called as free vitamin D, which enters the circulation. In the circulation, it is carried with respect to the different proteins. Then it enters the liver. In the liver, it gets what's called as 25-hydroxyvitamin D, which is the partial activation of the vitamin D. And the ultimate step or the terminal step where there is complete activation of vitamin D takes place in the 1,25-dihydroxyvitamin D. Okay, so remember, so 1,25-hydroxyvitamin D is the active form of the vitamin D which takes place in the kidney. So if there is no sunlight, if there is any liver damage, if there is any kidney damage, you will not have adequate level of vitamin D. Now, in addition, whenever you check vitamin D level in the blood, we are usually measuring the 25-hydroxyvitamin D. Okay, we are not measuring 1,25-hydroxyvitamin D. Another clinical implication is that in patient with kidney disease, there's no point in giving 25-hydroxyvitamin D. Why? Simply because 25-hydroxyvitamin D needs an active form which takes place in the kidney. So in the patient who have got kidney disease, we are going to give 125 hydroxy vitamin D as a replacement whenever there is vitamin D deficiency. So these are the two important clinical aspects of vitamin D biosynthesis. Now, this osteomalacia, which is basically a vitamin D deficiency in adults, usually seen in immigrants, those who have the reduced, those who have, these patients maybe have reduced level of vitamin D stores, or in Orthodox Muslim women who may cover their body part with the clothes, so that may decrease the exposure to vitamin D. Okay, so these are the two important what's epidemiological clues in when you're considering osteomalacia. So do look out for these two important clues in your equation scenario. Now, vitamin D deficiency can occur because of the malabsorption, because vitamin D is one of the fat-soluble vitamins, and part of it comes from the diet, part from this endogenous synthesis, a lack of sunlight, a lack of vitamin D in the diet, renal failure. As you know, kidney is important site for activation of the vitamin D. Drug induced, especially anticonvulsants. So phenytoin is the one drug which has multiple interaction with vitamin D. One is it induces the synthesis, induces the metabolism of the vitamin D. So whatever vitamin D level is, there will be metabolized and excreted quicker. In addition, phenytoin also decreases the absorption of vitamin D. Okay, so it's very important that some of the patients who got seizure disorder, who are on long-term vitamin D, long-term phenytoin, may have vitamin D deficiency. Okay, so you have to look for drug-induced osteomalacia and look for long-term history of seizure. And we have rare genetic condition. It's called vitamin D resistant rickets. So it's an X-linked dominant disease where the vitamin D receptor does not respond to vitamin D. So if you're going to check the blood levels of vitamin D, it will be very high, but there's a problem at the receptor level. A liver disease, cirrhosis, as we know, liver is one of the important intermediary steps in the activation of the vitamin D. What are the feature you're going to get? So rickets in children, we are not going to get much question on rickets because it's a pediatric topic. But to summarize, so they may get the what's called genu valgus and genu varus, which is the genu valgus is the lateral deviation of the leg, and genu varus is the medial deviation of the leg. Then they may have hypocalcemia signs, so patient may have tetany. Whereas in adults, osteomalacia predominantly present with bone pain. So they may have back pain, hip pain. These are the common presenting signs. Apart from that, they may have increased risk of fracture, muscle tenderness, and proximal myopathy. Okay, so vitamin D and calcium are very important for the function of the bone, the muscles, and the nerves. So in patient who got vitamin D deficiency, they may have proximal myopathy. That means they have weakness of the hip girdle, especially in the lower limbs. Now, what are the investigation finding you may come across? You may find low calcium because the mechanism of the action of vitamin D is that vitamin D increases the absorption of both calcium and phosphorus. So, in patients who have got vitamin D deficiency, what you will find is low calcium and low phosphorus, and the vitamin D level, which is the 25 hydroxy vitamin D, will also be less. Now, in additionally, what you'll find is a raised alkaline phosphatase. Now, alkaline phosphatase is derived from the three sources, usually from the bile duct, or from the bone, or from the placenta. Okay. Now, here the alkaline phosphatase, which is elevated, is from the bone. Now, alkaline phosphatase usually is elevated in patients when there is increased bone turnover. Okay. So, what happens whenever there's decreased mineralization is the matrix component starts to increase its production. Okay, so when there's increased bone turnover, you'll find a lot of alkaline phosphatase. X-ray, X-ray will show a definite feature in the children and some feature in the adults. So what's common in adult is what's called as the looser zone or pseudo fracture. So basically, these are linear area of low density surrounded by sclerotic border. Let me show this. So this is a looser zone. So this is the uh, um, X-ray of an hip. Okay, what you can see, this is the a anteroposterior view where we can see the head of the femur. This is the neck of the femur. This is the greater trochanter. This is the lesser trochanter. This is the intertrochanteric crest. What you are able to see here is a small fracture. Okay, this is not a true fracture. Basically, these are called a looser zone. Basically, what you're seeing is a break in the continuity of the bone, and you see a white border surrounding. That's called sclerotic border. Okay, so this is the looser zone. These are pseudo fractures. These are not real fractures. So how do you treat this vitamin D deficiency osteomalacia? We treat with calcium and vitamin D tablet. So this is the changes what you get in the rickets. So rickets usually they have rachitic rosary, which is the predominantly thickening of the costochondral junction. They have pigeon chest, pectus excavatum craniotabes, which is enlargement of the skull. They have knock knees. So this is the bow leg. They can have changes or maldevelopment of the teeth and the maxilla, and frontal bossing and delayed closure of the fontanelle. So these are the terms, these are the changes what you get in the pediatric. So in MRCP part 1 exam, you're going to get on the osteomalacia.